Sir, we are live.
Can we go ahead, sir? About 25.
Yes,
Yeah.
yes.
So, good evening, dear students, as well as esteemed faculties. It's an honor to welcome each and every one of you for today's 13th episode of Master Bedside Clinics in Nephrology. It has been a very interesting journey as of now, and we are very happy to welcome once again our course directors, Dr. Vijay Kher, as well as Dr. Lieutenant General P.P. Varma for today's program. So we request the course directors to welcome the examiners for the day, as well as the discussants, and accordingly take the session forward from so over to you, Dr. Varma.
Thank you very much, Mr. Raja, and welcome everyone for this 13th episode of Master Bedside Clinic in the field of nephrology. Today we are touching a different area, that is increasing the donor pool. You know that worldwide there is shortage of donors. If you look at USA, probably there are over 100,000 patients awaiting transplant. And in Indian scenario too, though we do not have exact data, but enormous number of patients are awaiting transplantation. There are different modalities to increase the donor pool. And today we are going to discuss those important issues which are really important. And I'm glad to say that we have got two stalwarts in the field of nephrology and who have got tremendous experience. I think they represent two largest transplant centers in India. Dr. Pratik, who is heading the Department of Renal Transplantation at R.N. Tagore Hospital, Calcutta. His team will be talking on ABOi incompatible transplant, and Professor Vivek Kute, who is again a master and authority in the field of swab transplant. His student will be talking about swab transplant. Before I go ahead, I'll request Professor Kher to say a few words, and then he can start the program.
Good evening, friends. Thank you, General Varma. I think you aptly said that actually there is marked shortage of organs for organ transplant, not only in kidney transplantation, but all across all other organs as well. But for kidney, obviously, CKD in epidemic proportions across the world, kidney transplantation is the best treatment option for patients of end-stage kidney disease, and therefore transplantation should be offered to almost everybody who has end-stage kidney disease. Unfortunately, because of shortage of organs, we are not able to do that. And in India itself, more than 2 lakh people develop end-stage kidney disease, at least every year. And we do not do more than 10,000 transplants. Vivek may be knowing more about it, but we don't do it more than 10,000 transplants a year. Most of these are living donor transplants, few disease donor transplantations. So we need to go a long way in increasing the donor pool by improving disease donor transplantation. There is definitely a movement in the right direction over the last decade or so, but I think we have a long way to go as far as disease donation is concerned. So till we are able to do, there are other methods by which we can increase the donor pool in amongst the living donor transplantation. And as General Varma said, that IKDRC, led by a lot of dedicated people, and Vivek being a leader amongst them, has been championing the cause of ABOi incompatible transplants and swab transplants, not only for increasing the donor pool, but also doing high-risk transplantations or sensitized patients, for which swab would be a very good, and we will hear from Vivek about it, and I'm sure the students are going to be also learning about it. And ABOi incompatible transplants, fortunately, many centers in India have started doing it, and I think Pratik's center is also very, very highly leader in this. So let's go straight to the case, I guess. Vivek, should we ask Nauka to go ahead
Yes,
with the
sir.
case? Is it all right, or would you like to say something before?
No, sir. We'll start
Okay.
with the case
Okay.
and
Okay.
discussions. Nauka, please start.
Nauka is a second year resident, DM resident at IKDRC, Ahmedabad.
Okay. Okay.
Um, um, shall I start?
Yes. Yes.
Good evening, everyone. I'm Dr. Nauka Shah, second year resident in nephrology at IKDRC in Ahmedabad. Today, I'm going to present a case of a two-way kidney pair donation transplant. So, beginning with my case, my primary patient is a 30-year-old married Hindu female housewife belonging to poor socioeconomic strata and residing at Indore in MP, who is a P2, A0, L1, and T1. First, going through her past history. She was a case of booked pregnancy with regular antenatal checkups during her second pregnancy, where in the 5th month of gestation, she was told that she had preeclampsia, and thereafter, she had poorly controlled hypertension in 2016. Just to mention here that her first pregnancy was in 2012, which was a full-term normal vaginal delivery of a live male child, which was uncomplicated, and currently also the child is alive and healthy. Coming back to her second pregnancy, in the 6th month of her gestation, she had started developing increasing pedal edema. So in her visits, her obstetrician told her that the heart sound of the fetus were absent and she had accelerated hypertension. Emergency LSCS was carried out then, and she says she also had increased blood loss for which around 6 pints of packed cell volume in total were transfused. Post-surgery, she was anuric for 2 weeks, wherein 7 cycles of hemodialysis were done via the right internal jugular vein DLC. Her urine output thereafter gradually started improving, and she attained a lowest creat of 2 within 3 months. Following this, she says that she had uncontrolled hypertension and progressive worsening of kidney function over the last 2 years.
Nauka, can I
Yes.
stop you here for a minute?
Yes, sir.
She had a normal pregnancy in 2016, and then
In 2012,
2012 was the
first pregnancy.
first pregnancy. Okay. That's
This was the second
okay.
pregnancy.
I thought
Got complicated, sir.
Okay.
So
What is the characteristics of? Do you think this is preeclampsia, a pure preeclampsia, or you think that this is something else?
So this could be pregnancy-induced hypertension as well, but it's very early in the onset. She was diagnosed with this in the 5th month of gestation itself.
So what do you make of this? Someone develops preeclampsia in 5th month. Preeclampsia is a disease of which trimester?
The last trimester, generally. In the last.
So it's a disease of primigravida, and it's a disease which occurs in the 3rd trimester usually.
Correct. Yes, sir.
So what are the causes of preeclampsia occurring in 2nd pregnancy, preeclampsia occurring in the 2nd trimester itself, or sometimes in the 1st trimester itself? So what are the various causes?
Sir, preeclampsia occurring in the 2nd trimester is obviously it is early and it is uncommon. But if she is having poorly controlled hypertension, and if she had developed proteinuria, which was already told to her in the 5th month itself, then this could be this could predispose her to preeclampsia, early preeclampsia, I mean.
So you said probably you weren't able to express it better, probably an underlying hypertension.
Yes, sir. Underlying hypertension.
Yes, sir. So underlying chronic kidney disease?
So she was not
protein.
Yes,
you said proteinuria. She is known to have renal dysfunction in 2016 required. So
sir,
you think underlying chronic kidney disease occurred somewhere between 2012 to 2016?
So it could have happened, but patient was not aware of it.
Yeah,
then.
was not aware of this. But that's exactly why I am discussing this, is that
yes, sir.
a occult or a hidden or an asymptomatic chronic kidney disease? Because
Yes, sir.
subsequent events tell you that it must have been either an underlying hypertension or an underlying chronic kidney disease. And the very fact that the postpartum events led to that deterioration. So it was a superimposed preeclampsia in a patient who already has an
Had chronic
underlying chronic kidney disease, probably, or maybe hypertension. So that's important.
Yes.
So history becomes important. These points
Yes.
are extremely important, that preeclampsia is usually a disease of the primary gravida, occurs in second trimester, third trimester. And once it occurs in the early trimester, so the causes could be chronic kidney disease, hypertension, proteinuria. Other causes, can you tell me other causes of
Early
preeclampsia? Yes, preeclampsia occurring. Any obstetric causes?
sir, are you
Multiple
multiple pregnancies?
Hydatidiform mole.
Hydramnios, multiple.
Hydatidiform mole. Okay.
Go ahead.
Go ahead.
Yes. So her urine output gradually improved, and she attained a lowest creat of 2, she says, in 3 months. Following this, she says that she had uncontrolled hypertension and progressive worsening of the kidney function over the last 2 years. Also, she agrees that she had poor follow-up during the COVID pandemic period. Hence, she had to be initiated on maintenance hemodialysis since February 21. Can you go to the next slide? She was initiated on maintenance hemodialysis via the right internal jugular vein DLC for 1 month, followed by formation of the left radiocephalic AVF. And she was on maintenance hemodialysis twice per week via the left radiocephalic AVF from February 21 to January 22, with interdialytic weight gain of around 2 kilos. She gives history of 1 AVF failure in Jan 22, during which for about 1 month, MHD was carried out via, again, the right internal IJV DLC. In the meantime, her left brachiocephalic AVF was made in Jan 22. In view of uncontrolled hypertension in Jan 22, she was advised to step up MHD to 3 times per week, in which she had interdialytic weight gain of around 1 kg. A patient had come to IKDRC in February 21, and here she was advised for renal transplant. My patient's blood group is O positive. Next slide, please. She was initially worked up for live donor related renal transplant with mother as donor. Her mother's blood group was B positive and she was 52-year-old. We got her anti-B titer done, which came out to be 512. She was explained for ABOi incompatible transplant, but they were unwilling for it due to increased costs as well as the high titers. Next, her father was evaluated. His blood group was O positive, but incidentally, he was diagnosed with single functioning kidney and hence refused. Her 25-year-old brother, who was O positive, as well as her 22-year-old sister, who was B positive, both were unwilling for donation, hence not evaluated. Now her husband was next evaluated as donor. His blood group also was O positive. He's a 31-year-old male with BMI of 18.4 with no comorbidities. Although they were ABOi compatible, on further pre-transplant evaluation, next slide please, it was found that she was told that she had a poor HLA match. She remembers the match being 1/12 and had flow cross match of T and B cells, both positive, and high antibody titers. She was informed regarding non-feasibility of transplant with husband donor, and if she wanted to pursue with husband donor, she would require desensitization, but she was reluctant due to, again, the high cost for the same. We then discussed the available options for her in this scenario. The first option we gave to her was kidney paired donation. We told her that she could register with our kidney paired exchange registry, where we would find her another appropriate donor recipient pair with whom her transplant was compatible. We told her that the pros of this would be that she would get an ABOi and HLA compatible pair, hence no significant increase in cost would occur as compared to the ABOi incompatible or HLA incompatible. And she would be given less potent immunosuppression, Hence, chances of infection would be lesser, especially in developing countries like ours. The cons of, I would just like to discuss the cons of this, that she would require a legal permission which needed to be taken, and she could have an increased waiting period since she was a difficult to match pair, her blood group being O positive and because of the sensitization. The second option we gave her was ABOi incompatible transplant with mother donor. Again, this she had already refused because of the cost, and also we would have to give her more immunosuppression. The pros would be that she would have less waiting period and no legal permission was needed for it. Third, she could undergo a deceased donor kidney transplant. The pros would be that the cost is lesser, and the cons would be that she would have increased waiting period since her blood group was O positive, and especially since she is a resident of Madhya Pradesh, and she would register for diseased donor kidney transplant in Gujarat, she would be in the second priority list, which would be much longer. And also, diseased donor kidney transplant could have a poorer long-term outcome. The fourth option we gave her was HLA incompatible transplant with desensitization protocol with husband donor. The pro would be that she would have a no waiting period, and the cons were that she would have increased cost, and she would be given more potent immunosuppression with more chances of infection. And the last option we gave her was that she could continue on MHD, which was not advisable for her since she was a young candidate, and also the patient was very motivated for transplant. Among these, she opted for kidney paired donation. Hence, we enrolled her in our kidney paired exchange registry. She had a waiting period of around 10 months, wherein we could find her a donor recipient pair in July 22. In IKDRC, we practice non-anonymous kidney paired donation. Hence, she was informed regarding her donor recipient pair, and both could easily communicate, exchange their reports, as well as get to know each other. So she knew that her donor was a 38-year-old male with blood group of O positive, and his BMI was 23.5. The donor had a good GFR. He had no comorbidities, and her HLA match with the new donor was 6/12, and her flow cytometry as well as CDC were negative, and she had no antibodies, HLA antibodies against the new donor. So after she was convinced that she was going to get a similar quality kidney as her husband's, she gave us informed consent for kidney pair donation. Both the pairs were thoroughly counseled by us as well as our transplant coordinator. They were explained that simultaneous surgeries shall be done. Now, just in brief about the patient number 2, which I would call as Mrs. J. Mrs. J is a 38-year-old married Hindu female, para 2, abortion 1, live 2, death 2, residing in Jam Kambadia in Gujarat itself, who was incidentally diagnosed with CKD with bilateral small kidneys in 2008. Next slide. She was on conservative management till June 21, after which she was initiated on maintenance hemodialysis 2 times per week via left brachiocephalic AVF in June 21. We believe her reason for sensitization is a bad obstetric history. Next slide. First, she had an abortion at 3 months of gestational age in 2012. Second, she had an intrauterine death at 8 months of pregnancy in 2015. Third, she had another intrauterine death at 8 months of gestation in 2019. She gives no history of PCV transfusion. Mrs. J has a blood group of A positive. And her reason for enrolling into kidney pair donation was that on evaluating her mother as donor for live donor related transplant, her mother was a 60-year-old female with blood group of A positive, but she was found to have uncontrolled hypertension with end organ damage and hence declared unfit for donation. Her father had already passed away, and her 2 brothers, 50-year-old male and 45-year-old male, both A positive, were also unwilling for donation. Also, her 2 sisters, 52-year-old female and 46-year-old female, both A positive again, were also unwilling. Her husband, Mr. A, who was a 38-year-old male, already with blood group of O positive, was also evaluated. She was told that she had a poor HLA match with her husband, with cross-match report positive and extremely high titers of antibodies. Hence, her transplant would not be possible with her husband. Next slide. She was also given similar options for further management as patient number 1, and she also thought kidney pair donation was the best option for her. A special mention on why she was reluctant for deceased donor kidney transplant was because of the long waiting period. Especially since she was a resident of Gujarat, we had offered her this option, but she says that her village, Jam Khambhadia, had a long distance from Ahmedabad and she was reluctant to travel to Ahmedabad on emergency basis for every cadaver call at any time. Hence, it was inconvenient for her, and also she was wary of the quality of the kidney that she would get. Hence, she had refused deceased donor kidney transplant. So patient 2 had enrolled for kidney pair donation in March 2022, and she had a waiting period of less than 6 months in which we could find her an ABO and HLA compatible donor. Donor of patient number 2, Mrs. L, which was husband of patient number 1, is a 31-year-old male with blood group of O positive with BMI of 18.2. She also had an HLA match of 6/12 with cross-match negative and no DSA. So after all the necessary investigations and consent, their files were sent for legal permission, next slide, which took around 2 days. We had taken hospital-based authorization committee's permission as well as permission from the state-based authorization committee as per Transplant Human Organ Act 2014. Next slide. So now to summarize both my patients, patient 1 and patient 2. So my patient 1 is a 30-year-old married female, para 2, abortion 0, live 1, death 1, residing in Indore, MP with native kidney disease, probably postpartum cortical necrosis, with history of 6 pints of blood transfusion, with hemodialysis vintage of 1 year and 7 months, with live donor related transplant not feasible due to unwillingness of the siblings, unwillingness for ABO incompatible transplant with mother, single functioning kidney of the father, and sensitization with husband. Hence, consenting for a kidney pair donation with a waiting period for kidney pair donation of around 10 months planned for KPD with donor husband of patient number 2, Mr. A, who is a 38-year-old male with no comorbidities with BMI of 23.5 with HLA match of 6/12, negative CDC, FCM, and no HLA DSA. Also, now patient number 2 is a 38-year-old female, married, para 2, abortion 1, live 0, death 2, residing in Gujarat, diagnosed with native kidney disease, probably undiagnosed, in 2008, with bad obstetric history leading to sensitization, with hemodialysis vintage of 1 year and 2 months, with no history of PCV transfusion, with live donor related kidney transplant not possible due to mother having uncontrolled hypertension, unwillingness of the siblings, and sensitization against husband. Again, planned for KPD with a waiting period of 5 months of transplant with donor, that is husband of patient number 1, Mr. L, who is a 31-year-old female with BMI of 18.2, no comorbidities, HLA of 6/12, negative CDC, flow cytometry, and no HLA DSA. Next slide. Now moving on to the transplant history. Next slide. Simultaneous two-way kidney pair donation transplant was done on the 1st of September 2022 with induction agent thymoglobulin, rabbit ATG for both the patients. My patients are not aware of what dose of ATG that was given to them since both were operated under the government scheme. Both were told that their surgery went smoothly without any complication. Patient 1 had on-table urine output of 1 liter and patient 2 had an output of 700 ml. They were kept on triple immunosuppression and discharged on post-op day 5 with creat 0.8 of patient number 1 and 0.9 of patient number 2. Both the patients were allowed to meet each other before as well as after the transplant. Next slide. The post-transplant history. Patient number 1 is currently on prednisolone 20 mg, tacrolimus 0.1 mg per kg with tac level of 10 nanograms per ml and morpholate 360 mg TDS. Her last serum creat level is 0.88. And patient number 2 is on prednisolone 20 mg, tacrolimus again 0.1 mg per kg with tac level of 10.45, morpholate 360 mg TDS. And her last creat is 0.99 mg per deciliter. Just in brief, the general examination of both the patients was normal. Their BP is normal. BMI is 18.5 of the first patient, and the second patient BMI is 19.6. Both have a longitudinal, healthy-looking scar in right iliac fossa with no redness, discharge, or tenderness. And systemic examination is normal of both the patients.
Dr. Kute, you can start
Yes, sir.
asking your questions
Yeah.
as well as.
So in this case, 2 female underwent kidney pair donation transplant. So is there something unique to this as per the Indian transplant scenario is considered?
Especially unique to this case would be that in India, there is a lot of gender disparity among the recipients. A majority of the recipients are males and majority of the donors are females. In this case, we have both the recipients that are females and their respective donors that are males. That is one peculiar thing.
So what are common causes of sensitization in the transplant?
Sensitization, as in our case, can occur because of pregnancy. Also, it can occur because of PCV or any blood product transfusion previously, or because of any prior transplant also. Also, certain infections may also sensitize the patient.
How you will do immunological assessment in any sensitized patient?
So, immunological assessment we can start by, as in our setup, we first start with doing the single antigen bead as a Luminex assay. We do a virtual cross match. We also have the HLA of the donor and the patient. We do a virtual cross match with the single antigen as well as the HLA. Next, we proceed towards the CDC lymphocyte cross match as well as the flow cytometry.
So what is
And we can see
average cost of this different immunological investigations? What is cost?
Sir, in our setup, the single antigen Luminex is costing around 30,000. The other cross match and the CDC and flow are costing around 2 to 3,000.
So how you manage swap registry in your center?
So we have an automated, we have an APD, a software, automated software in which we enter the patient as well as the donor's details. We also enter their antibody assays, and we get a compatible or a non-compatible pair in it. We enter all the details and we can derive the pairs from it.
Nauka, how
We
many?
maintain the kidney paired registry for it.
Yeah, Nauka, how many patients you have in this registry at one point of time?
Sir, we every month at least around 50 to 60 patients are getting enrolled, and at present we must be having more than 600 to 700 patients in the registry.
And how many transplant swab have been performed in your center?
So 500 swab transplants, around 500 swab transplants have been already performed in IKDRC till now.
Okay. And it is something like this had 1:1. That means 2 pairs were transplanted. I believe your center has done many more transplants also, 5, 6 or 10 pairs.
Yes, sir.
I think Dr.
Yes.
Kute may be knowing. He can answer that. What
Yes.
has been the maximum number of...
Yes.
Just in pre-COVID, sir, we perform a chain of 10 patients and 10 donors who were operated over a period of 2 weeks. That is in a non-simultaneous way. So when you prefer short chain and when you prefer a long chain?
Sir, short chain is the ideal way. 2 to 3 way transplant is the ideal and the optimal way to go. But long chains we can do if we have a highly sensitized, difficult to match pair, then we can also go for a longer chain.
So what will be required to perform the long chain?
So for long chain, we generally go for for simultaneous transplant. A very good and a big, huge surgical team would be required to perform so many surgeries. A very big infrastructure would be required.
There are two issues I wanted to ask. One was you are having a non-anonymous donor recipient chain.
Yes, sir.
And many centers have anonymous, like abroad, there's an anonymous chain. And which is better and how?
So in our experience, non-anonymous chains, non-anonymous pairs are better because that helps the patients to build confidence towards the kidney that they're getting, as well as the doctors. They know that what kind of donor age, which is the main concern of the patient, the donor age, and the GFR. Also now the patients are very well aware of things like this, so they know what they are getting, and hence their confidence and the satisfaction towards the doctors increase, and hence more willingness for swab transplant, since they are more confident about it, more willingness, and there would be increase in number if we go for non-anonymous
Kute, your comment.
transplant.
No, Nauka, just tell me before Dr. Kute answers this question. Suppose the other donor pair, the donor age was 60 years of age or 65 years of age. But the GFRs were okay. GFRs were good. So what, in your opinion, is the impact of doing such a transplant? You think that
So
the pair who gets a 65-year-old donor will get an inferior kidney, or what's the impact of age?
No, sir, most of the recent studies are saying that if the donor age is between 18 to 65, there is no significant difference noted in the studies in the outcome. So I would advise to go ahead. If the HLA, the main prognostic factor is the HLA match and not the donor age. So
actually,
if the
age.
HLA match is good.
Yes, age is a very relative kind of a factor for outcomes of transplant. And in fact, as you said rightly, that 18 to 65 years of age, people have looked at older donors versus younger donors and found that probably the overall short-term and long-term outcomes of such transplants has not been very different. Whereas both these people, the recipients, had incompatible husbands as far as immunological risk is concerned. And therefore, if they had gone ahead desensitization, what, in your opinion, would be the outcome of such transplants? So if you had said, okay, no swaps, let's desensitize you, and we will go ahead and do a transplant. So what do you think would have been the outcome of such transplants? In addition to the cost, in addition to the cost that you talked about, but what would be the expectation? What is your expectation of such transplant?
The long-term outcome of HLA incompatible transplant, despite the sensitization, is still poorer than transplants with HLA compatibility.
Yeah, no, can you give me some numbers? Means this is a general kind of a statement, will be poor, but how poor at 1 year? What is the chance of rejection, loss, survival, 5-year survival? So what do you think are the outcomes?
I'm not aware of the exact data currently.
That's important. Actually, there is a 40% chance of an acute antibody-mediated rejection in these, and again another 20-30% chances of graft losses within 1 year, and 5-year survivals are poor. Graft survivals are poor in such transplants. Can you name few centers in the world which are doing high volume desensitization in this group of patients? Can you name three important centers in the world? In addition to your center also does some desensitization, but in addition to your center, which is obviously world renowned, but what else? Other centers?
Some 2 US centers you can name.
Sir, I'm not aware.
Dr. Montgomery Center at Johns Hopkins initially. Now he is no longer at Johns Hopkins. And
Mount Sinai also.
Cedar Sinai.
Cedar
Sinai. Yes, Cedar Sinai. Yeah. Dr. Stanley Jordan. Yeah, they've been the groups. These are two, Johns Hopkins and Mayo Clinic is again another center which does fairly high desensitization protocols. Okay.
Professor
Yeah, Dr. Kute, you can go ahead.
About anonymous and non-anonymous donors. And the second question will be, what about the bridge patient? If you have got a long chain, does the bridge patient sometimes recede back?
Yes, sir. That is a very that is a possibility we cannot ignore. In case of if the bridge donor, since the recipient is his recipient has already received the kidney, could and he also can withdraw the consent to give the kidney. Hence, there is a problem of donor reneging in case of bridge donors, and hence we prefer if simultaneous transplants occur. It's always better.
One more problem, I think, is about the authorization, which people should be aware, because whenever you have got long chains, like this patient, you said the consent came within 2 days.
Yes,
that is spectacular, very fast. Because the Human Transplant Act of 2011 also requires that you have to take permission from State Authorization Committee. And if somebody is from an outside state, you have to take clearance from outside the state. And that is a very lengthy process. It can take months together, right? So that will be a drawback of long chain. Your comments and how you are going about.
Sir, according to the amendment done to the THOA Act in 2014, just permission of the state in which the transplant is happening and the institute's authorities' permission is they've declared that is probably enough to legalize KPD. And luckily, my patient got it in 2 weeks, but general time in Gujarat is around one month.
Professor
to get the legal.
Professor Kute, is it required from the respective state also? Professor Kute?
Yes, sir.
No, is the permission required if you have got a long chain and some of the recipients are coming from different state?
No, not required, sir. No. Permission from other state is not required.
Now it is only the state where the transplant is being performed?
Yes.
The institution. That's it?
Yes.
And your comment about anonymous and non-anonymous donor in between your...
Sir, obviously, if patients and donor are allowed to meet each other, this increases trust and transparency between patient and donor. And if we avoid them meeting, they usually have more query in the mind. So I think because of the socio-cultural situation, it is best that they should be allowed to meet each other. In our center, we also allow them to share medical reports with each other. They can take opinion from their family doctor or referring doctor as well. So I think if we keep it open, this increases the transparency. And regarding the permission, since one patient is from Madhya Pradesh and other patient is from Gujarat, we get permission in 2 days from our state-based authorization committee. So as per 2014 amendment, the hospital, state or district in which transplantation is proposed to be done should give permission for the swab transplant, and there is no need to take permission from different states when patient and donor are from other states. Otherwise, this will unnecessarily increase the waiting time.
The students should know that the Human Transplant Act 2014 allows and legalizes swab transplant. Is that right?
Yes.
Okay. What is the 5-year survival of Professor Kher put a question to Nauka that if you are doing a sensitized transplant, possibly 5-year survival is less than 50%. And here also you are taking patients who are unrelated. They possibly do not have any HLA match. What is the 5-year survival in your center and reported?
So 5-year
Graft
survival, 5-year survival at our center is, sir, it is around 60%, 60 to 70. Sir, majority of the grafts are surviving. The only in between, if there is any sepsis event, we have seen that only then there is some problem. But overall percentage, 60, around 60 patients have a good graft, optimal graft function by 5 years.
Professor Kute?
Because here we are doing, sir,
We have reported our survival, sir. The survival is 90%, and the report is published, sir.
There's a graft survival.
Yes, sir. And patient survival is around 85% because in Indian scenario, the main issue is the death with functioning graft because of infections, the tropical infections, tuberculosis, and patients who are coming to the public sector hospital, they are malnourished. So they have the additional issue of infections.
Okay. Professor Kher, any other comment? I think.
No, I think this is fine. People must be aware that actually putting patients or giving, especially patients who are at high immunological risk, paired kidney donation is obviously one of the best decisions, and the short and long-term survival of such transplants is much better than desensitizing these patients and putting huge costs, as well as managing infections in our country is extremely. So paired kidney donation, exceptionally good choice for such patients. It's only that you need to have large pairs. And what IKDRC has been able to do is to create this. I only hope that we are able to create more regional kind of registry so that larger number of people are able to get into this kind of things. So this is something which does require coordination among centers. The nephrologists must be, and the surgeons must be in same tune with each other's protocols and all that. That puts in difficulty, but I would agree that large programs like IKDRC in having this, and then they are this sort of for Gujarat also, they permissions and all those given much. You and I in private may not be blessed with that kind of permissions. There is always a sin on the transplants that we do. So there is going to be some difficulty, but I think all the points taken is something which is extremely good for the patients. And I think more and more centers coming forth to do these. So I think it's much better than comparable all because the costs are less, the immunosuppression is less, and you are overcoming the barriers, the immunological barriers, and that's nothing like it.
I think.
Thank you. Thank you. I think Nauka, we can go over to the next case because Nauka, thank you.
I think we must thank Professor Kute, who has been a master and authority in the field of swab transplant in India. And it's very creditable. He recently got an award from TTS for doing a yeoman service in this field. Congratulations, Professor Kute. And thank you, Dr. Nauka, for a very nice presentation. What is only the question coming from audiences, how come both the people had 6x12 HLA match, both the couples? Yeah. Anyway, we move to the next case. I think Professor Pratik Das is in now. So we will request a student to proceed ahead. He is again a second-year student, Dr. Alok Kumar Gupta. Please go ahead, Dr. Alok.
Yes, sir. My slides are visible?
Yeah, slide is visible. Make it full screen.
Yes.
Yeah.
Good evening, teachers. I am presenting a case of a 32-year-old male, Mr. S, who is a resident of Darjeeling, a graduate in BA, shopkeeper by profession. He underwent an ABO incompatible renal transplantation 18 days back. His presenting complaint is rise in serum creatinine level and reduced urine output since 7th post-operative day. To start with the history of presenting illness, till April 2015, he was all right when he had complaints of some uneasiness at his workplace, for which he showed to a nearby physician and found to have raised blood pressure. On further evaluation by the physician, he was found to have raised creatinine of 2 mg per deciliter and protein in urine as told by his physician, and was referred to a nephrologist. He underwent a renal biopsy as the kidney size were of normal size and was reported to have IgA nephropathy and was started on some treatment. Uh, then till January 2021, he was apparently all right. Then he started having complaining of nausea and vomiting with reduced appetite, for which he consulted his nephrologist and was found to have creatinine of 9.2 milligram per deciliter and was started on hemodialysis after a temporary hemodialysis catheter insertion in right internal jugular vein. And at AV fistula, radiocephalic fistula was created on right side, but it underwent a primary failure, after which a chronic tunneled venous catheter was inserted in right internal jugular vein and was continued with maintenance hemodialysis twice per week. He continued injections for increasing hemoglobin and was vaccinated for hepatitis B and COVID-19. His residual urine output was 100 to 150 ml per day. There was no history of any blood transfusion. On December 2021, patient came to us for came to our center for renal transplantation with his mother as a potential voluntary kidney donor, but donor's blood group was A positive and recipient's blood group was O positive. So in view of ABO incompatibility, he was given option of desensitization versus swab kidney transplant. As there was no matched pair for swab transplant and patient was not doing well on hemodialysis, he opted for ABO incompatible transplantation. So the workup for ABO incompatible renal transplantation was done. They have haplotype match, anti-HLA antibodies were negative. The CDC cross match, T and B cell cross match was negative, and the baseline IgG anti-A antibody titer was 64. So patient underwent desensitization as per our hospital protocol. 2 weeks before the transplantation, he was given an injection named rituximab 100 milligram. He got admitted 1 week before the transplantation and was started on tacrolimus 0.1 milligram per kg per day and mycophenolate 1 gram per day, and underwent 3 sessions of plasma exchange followed by an injection named IVIG 10 gram after each sessions of plasma exchange. After the desensitization, the pre-transplant IgG anti-A antibody titer was 4. The pre-transplant CDC T cell cross match was negative, and the CD20 level was less than 1%. Then patient was given induction therapy with ATGF, grapholon 6 milligram per kg body weight, and methylprednisolone before transplantation. On the zero post-operative day, patient underwent renal transplantation surgery uneventfully and had immediate urine output and was maintained on tacrolimus 0.15 milligram per kg per day, mycophenolate 500 milligram thrice a day, and oral prednisolone 20 milligram once daily. Patient had immediate graft function with adequate urine output about 5 to 6 liters per day with nadir creatinine level of 1.2 milligram per deciliter on 6th post-operative day. But on the 7th post-operative day, his urine output dropped to 50 ml per hour with rise in creatinine to 2.3 milligram per deciliter in 1 day. So we did workup for graft dysfunction. His USG graft was done with Doppler, which showed reduced diastolic flow. There was no evidence of any infection. The tacrolimus trough level was 9.2 nanogram per ml, and IgG anti-A antibody titer was 64, which was increased from the and was equal to the baseline titer. And the graft biopsy was done, which showed peritubular capillaritis with C4D positive stain, and it was labeled as acute antibody-mediated rejection, for which it was...
Just interruption. This was how many days after transplant?
Sir, 7th post-operative.
Okay, please go ahead. Please go.
Then patient was treated with 5 sessions of plasma exchange followed by IVIG of 10 grams after each plasma exchange. So total of 50 grams of IVIG was given, after which patient responded well and the urine output improved to 150 ml per hour, about 3.6 to 4 liters per day. And the serum creatinine level also improved to 1.5 milligram per deciliter, and IgG antibody titer was reduced to 16. There was no past history of there was no history of any diabetes, hypertension, or tuberculosis. In personal history, he consumes mixed diet, no history of any addictions or recreational use of illicit substances, has normal bladder and bowel habits. Patient is unmarried. There is no history of any renal disease in parents or siblings. So to summarize, my patient is 32-year male who is a known case of end-stage renal disease on maintenance hemodialysis twice a week through tunneled venous catheter for the last 1 year with a native kidney disease of IgA nephropathy, underwent ABOi incompatible renal transplantation with mother being the donor, with baseline IgG anti-A antibody titer of 64 and pre-transplant titer of 4, had immediate graft function but developed graft dysfunction on 7th post-operative day in the form of acute ABMR, which was treated with 5 sessions of plasma exchange and 50 grams of IVIG, to which patient is responding well with improvement in the urine output and creatinine level. On clinical examination, patient is conscious, cooperative, afebrile, the pulse is 78 per minute, regular, normal in volume and character with all the peripheral pulses palpable. Respiratory rate was 16 per minute, blood pressure was 150 by 80 millimeters of mercury in left arm in supine position. The height is 168 centimeter, weight is 60 kg, body mass index to 21.25 kg per meter square. There was no pallor, icterus, cyanosis, clubbing or lymphadenopathy or edema. There is a tunneled venous catheter inserted in the right internal jugular vein, scar on the right forearm, the site of AV fistula. There was no bruit, and the surgical site has healed wounds after 2 weeks of the surgery. On systemic examination, on per abdomen, there is presence of healed wound from right lumbar to iliac region. There is no bruit audible. There is no graft tenderness. The neurological, cardiovascular system and respiratory system were within normal limits. So my diagnosis is antibody-mediated rejection in ABOi incompatible renal allograft recipient with native kidney disease of IgA nephropathy.
Dr. Pratik, please take over.
So, Dr. Alok, your patient is a case of IgA nephropathy, and he opted for this ABOi incompatible transplantation.
Yes, sir.
So, can you tell me why he opted this kind of transplantation, even after explanation of everything?
Sir, first of all, he was on maintenance hemodialysis. He had multiple vascular access failure issues, for which he was on tunneled venous catheter, and he was also not doing well on the hemodialysis. He has multiple LVF episodes, accelerated hypertensions, and if more ultrafiltration was done, then he used to develop cramps very frequently, and overall he was not very well on hemodialysis. So it was necessary to go for the transplantation as early as possible. As there was no match to go for the swab transplant to do ABO compatible transplant. So we did not, and there was no donor other than his mother. So we did not had any other options to go for to wait. So we planned for ABO incompatible transplants.
So your patient has a basic antibody titer was 64, and your your friend was telling that they had a titer of 512. So they was not very much keen on taking this ABOi incompatible transplantation. So can you tell me whether the baseline titer is important, or how does it impact in the subsequent transplantation? If a high titer has a high risk, low titer has a low risk. Does this rule follow?
Sir, before transplantation, definitely high titer is a risk factor. But if after desensitization patient responds well, and the titer is optimized to the standard titer as less than 32. So then the prognosis remains the same. And in the post-operative state, if there is rising titer, or then there can be a risk of further rejections, and the prognosis can be poor. But in pre-transplant state, if the patient is desensitized well and his titers has been optimized, then the outcome can be comparable in both the cases.
Yes, initially it was thought that the high titer has a higher risk, low titer has a lower risk, but that is not true. In many studies, it has been shown that even including your study from your institute comparing less than 256 and more than 256, it shows that it ultimately doesn't affect. It depends on from which kind of B cell antibody is coming and initially, and how they are motivating complement to precipitate rejection. These are important.
Yes.
Yes, this is the cost of desensitization increases if your baseline titer is high, but otherwise it is not very important. So yes. in this patient, in your you have told that this IgG titer you have measured. Do you measure IgM titer also, and is it important?
Sir, actually, IgM and total titers are only measured, and overall IgG titer is only important, sir.
Yes, because this IgM, they cannot attract this complement, and their chances of precipitation with these antibodies are lesser compared to this. So we have tested actually this IgG antibody titer.
Yes. Alok, can I ask you one question? Dr. Pratik told you that he was asking you that why did this patient choose ABO incompatible transplant? You said that she had only one donor. Do you think that ABO incompatible transplant is better than maintaining this patient on dialysis? What are the outcomes in dialysis, and how do you compare ABO incompatible outcomes in such a patient? Because that would be the reason why a person would still want to do a transplant.
Yes.
Because this transplant may be better than the long-term outcomes on dialysis. What's the long-term outcome on dialysis?
Sir, in long-term outcome of dialysis, the survival rate in our country is almost 40 to 50%.
At what?
5 years.
What?
5 years.
At 5 years, 50%.
This is the Western data.
Yeah, this is US data.
This is US data, not Indian data.
So US data is 5-year survival, 50%.
Yes.
And 10-year?
10 years, sir. Exactly value, sir, I am not aware.
You don't know. And what would be the 10-year survival of an ABO incompatible transplant?
Sir, there are not much studies on the exactly.
Anyway, I think Japanese have been doing these transplants since 1989. So they have at least published
many studies.
10-year survivals before 2004, and then 10-year survivals even after 2004. So there are many studies, and even US data. Dr. Montgomery presented New England Journal of Medicine also has a long-term 10-year survival data of about 1,000 patients. So what's the 10-year survival of ABO incompatible transplants?
Sir, exactly value, sir, I am unaware.
You can start with what is the 10-year survival of living transplant? Haplo-matched living transplant.
ABO compatible.
Sir, 80 to 90%. Sir.
Yeah, 10-year survival of living donor, yes, transplants.
Around 80%.
Yeah, 80, 85% and above, yes.
What about cadaveric?
So, cadaveric, sir,
20% less.
Yes, sir. That is also 60 to 70. Yes, sir.
And what about the, as Professor Kher has asked you, what is the 10-year survival of ABO incompatible transplant?
So 10-year survival, yes, sir. 10-year survival in ABO compatible and incompatible are same, sir. Almost same.
Yeah. So that's the answer. That overall, especially the Japanese studies suggest that the overall. So what is the graft survival in ABO incompatible transplant? Where do we lose the grafts in ABO incompatible transplants?
Sir, in the initial period, in the 1 year, 3 years, and 5 years, there are more risk of there are less graft survival in case of ABO incompatible transplant as compared
in the first year itself. Usually, yes. And the graft losses are because of what in ABO incompatible transplant?
Sir, more sir, patient graft loss, sir.
Yeah.
Yeah.
Graft loss in ABO incompatible transplants in the first year occur because of what? And most of these grafts are lost within first year. By and large, otherwise, rest of the follow-up of these patients is similar to ABO compatible transplants.
Sir, more because of rejection, sir.
Which kind of?
Accelerated
antibody, acute antibody-mediated rejections. Yes. And usually many of these are PMAs and do not recover the way your patient recovered or responded to the treatment. Yes, so maybe we will come to that discussion also sometime.
Your comment, because this is a teaching session, which method you recommend for doing the titers?
Sir, we used to do the
is it the tube method or gel method, and why?
Yes, sir, gel bead. We used to do the gel bead test, sir.
The recommendation should remain that preferably one should do gel method, but Indian guidelines say if it is not available, you can go ahead with tube method, but gel is a preferred method. Well, your comment, Dr. Pratik Das.
Yes, sir. Yeah. The tube method is that it is very cheap and it can be done at any places. It can separate IgG, IgM, but it depends on the inter-observer variation. It is observer dependent. So initially we are very comfortable by doing these tests, but usually you get the results on the lower side. But simultaneously, because of the inter-observer variation, there are some discrepancies. So we opted for this gel cut technique, and this is automated and analyzer dependent. So it is not very costly also, although this is not the best method like the flow cytometry. So it is the reasonably acceptable, and this is a very good method of guiding. Only one problem we are facing, they are showing a slightly higher titer. So their patients are requiring 2-3 more plasmapheresis compared to the previous. So we are following this gel bead or gel cut technique by automated analyzers.
A question from audience is how often you are doing titers before transplant? Is it before and after each plasma exchange?
Yes, sir. So before transplantation, first we do a baseline titer, and then when the patient get admitted for the transplant, then we used to do a titer, and then we start plasma exchange, and daily till the we get the optimum level of antibody titer, we do the antibody titer daily, sir.
Daily means after how much time of finishing plasma exchange? We do it immediately after plasma exchange, should after half an hour, 1 hour, 4 hours, what should be the time gap?
So we actually means almost after 12 hours. Sir.
That will become too long. It become next day. You are doing plasma exchange every day or alternate day?
So alternate day, sir.
Yeah. Okay. So what does Professor Pratik say? Because I thought 2 to 12 hours is the time given. Any time, preferably around 4 hours when the equilibration has stayed. Because what you were talking about, IgM has got high molecular weight. So when you are doing plasma exchange, it gets removed easily. It is not going out of the circulation. Therefore, IgM level titer is not significant. As you rightly said, IgG is significant. Yes. All right. And how many hours after, Professor Pratik Das? What is your take? And
actually, we are more keen on what is the exact titer before at the time of surgery. So usually, as Dr. Alok was telling, we do the plasmapheresis, we do the around 10 to 12 hours after the plasmapheresis, and we try to keep it as close to as surgery possible and get the ideal titer. Because sometimes we did and titer 4 hours, 6 hours after the plasmapheresis, and titer was slightly lower, say 32, but after 12 hours, it just went up to 64. So usually we do the plasmapheresis followed by IVIG. The next morning, early morning, we send it is around 10 to 12 hours. I think that is that gives us a good result.
And how is the post-transplant monitoring? That is for students. Do you recommend post-transplant monitoring or no?
Yes.
Yes, sir. We used to do the post-transplant monitoring daily, sir.
Daily you are doing for how much? Fortnight?
Till the patient get discharged, sir.
No, that is 1 week you mean.
Yes, sir. Almost, yes, sir.
Like this patient, is it common to have a, like this patient who had rebound or again after 1 week?
Yes, sir.
If you are doing every day, in this patient, you must be doing every day then.
Yes, sir.
So that means 7th day it got picked up.
Yes, sir.
Is it common? And why it should occur?
Sir, it is not common, sir. It is as per our center, it is very uncommon. Means in very few cases we used to we have encountered antibody mediated rejections related to ABOi incompatibility, sir, because of raised titers and because maybe, sir, as the patient was desensitized before transplantation, and after 6-7 days, there was increase in the titers.
Do you do and DSAs in these patients?
Yes, sir.
Even so, there were no DSAs in this
No.
patient.
No.
You do DSAs in all. You do a single Luminex kind of a DSA in ABOi incompatible transplants.
Yes, if the, sir, in this case, sir, ABO that antibody titer was high, so we were.
No, I'm not talking of ABO titer. I'm talking of anti-HLA antibodies looking for donor-specific antibodies. Anti-HLA
Yes, sir.
donor-specific.
We used
Did
to
you,
in case of ABM.
in this patient, was a Luminex DSA done?
Yes, sir. It was negative, sir.
Mhm.
No, you did CDC crossmatch. You did a flow cytometric crossmatch, and you did also a Luminex DSA looking for anti-HLA class 1, class 2.
Yes, sir. Yes, sir.
No.
Do you do it in all patients, Pratik?
No, actually, we initially do a PRA screen, DSA PRA screen, because it is costly. If there comes to be a positive in class 1 or class 2, then we go for a single antigen bead test.
So in this patient, the PRA was negative.
Negative.
So then a DSA was not done.
Not done, exactly.
Yeah, no, I'm only saying that, see, the antibody mediated rejection could be an ABO incompatible lack of accommodation. Accommodation didn't occur. So that was the cause of antibody mediated rejection, which is related specific to. And what is the difference between this rejection in an ABO incompatible transplant and comparison to, say, anti-HLA mediated acute antibody mediated rejection? What has been the current kind of difference between these two kind of rejections?
Sir, that anti-HLA can be due to some preformed antibodies.
Yeah.
Which have been expressed after transplantation.
Yeah, no, I'm talking of presentation wise. What is the kind of a difference? Histological, others, much commoner, a particular kind of histological picture in one, the other may show different kind of.
Anything with TMAs and all?
Yes, sir. In ABO incompatible transplantation, more commonly they present with a picture like thrombotic microangiopathy, sir.
Yeah, that's the commonest kind of acute antibody mediated rejections, the commonest ones, and that's why this is more common. This doesn't respond as well to the plasma therapy that was given. So your patient, so that makes me wonder what was the reason for your acute antibody-mediated rejection. I'm not so sure that this was lack of accommodation, because if it was lack of accommodation, then this patient would not have reversed his acute antibody-mediated rejection. So that's why I was wondering whether this was probably related to maybe an anti-HLA antibody-mediated rejection. So I would probably look at anti-HLA antibodies in this patient as well. And I would also look at complement and other factors sometimes to see if there was the biopsy histology. You didn't give me the details.
Yeah.
You only said that this was acute antibody-mediated rejection. TMA could be part and parcel of an acute antibody-mediated rejection as well. So I am not sure what was found on histology in this patient.
But always also keep in mind that antibody-mediated rejections are less in ABO incompatible transplant, simply because you are also removing complement when you are doing plasma exchange. Professor Pratik Das, your comment, please.
Yes, sir, you rightly said that we are in the literature, and also we don't encounter much of this clinically significant antibody-mediated rejection due to ABO antibodies. We get sometimes the rise in the titer, but doesn't affect the graft, or maybe the accommodation process starts early in. But when they appear, they are very refractory to treatment and very difficult to salvage the graft. In this case, basically, I think the antibody-mediated rejection, the intensity was lower. Maybe the titer didn't go much higher. That may be one reason. Or other reasons, there may be some non-HLA, non-ABO antibodies that we didn't test, because this HLA is a preformed antibody, clinically significant anti-HLA antibodies. If it were present in those situations, the PRS screen would have been positive, at least a mild positive, moderate, like that. So it may be a non-HLA, non-ABO antibodies that we don't commonly test. So that is a possibility. So our thing is that initially we used to respond to the rise in the antibody titer with very high panic, and we used to get a prophylactic plasmapheresis without, even though there is no graft dysfunction. But with time, we have learned that yes, we can wait and observe until and there's graft dysfunction, we don't react actually. So this antibody, fortunately, this patient recovered, maybe related to ABO, maybe something else. But as this patient has anti-HL antibodies negative, so if it is a non-ABO system, I will prefer it maybe a non-HL and non-ABO antibodies maybe. We didn't test for that.
Yeah, it is very unlikely to be a sort of an antibody-mediated rejection, which is commonly found in patients with ABO incompatible transplant time, which is more like a TMA kind of a disease that you find, and which is usually not amenable. And as Pratik said, most of the time we might have to do a graft nephron. Fortunately, these events are rare; they don't happen very commonly, and which is good. Because usually it's very frustrating for the treating unit as well when you put a graft and within few days you have to take out the graft. So it's not a good feeling at all. But those are fortunately rare; they're not common. So I guess this kind of rejection probably maybe either non-HLA or some other factors, which might be, because the response was very good, and you've been fortunate that you recovered the graft function completely.
So it's in one discussion, Professor Tanabe was telling that before 2004, when their desensitization protocol included the splenectomy, in those situations, they used to get this kind of pictures much lesser. But after 2004, when they started rituximab, and in his opinion, he was not considering it as a rejection at all. He was telling this may be some kind of TMA per se, and they used to treat only by eculizumab in these groups of patients. So he was not telling that it is a rejection. It is a TMA that has happened in an ABO compatible transplantation.
Yeah, yes, I agree. I have had also same kind of discussion with him, and he usually feels that this may be a second hit, and there may be some complement deficiencies in an occasional patient. And in those patients, a second hit, a transplant producing an endothelial damage, and that results in further reduction of complement and the TMA occurs. So he feels that this is all complement mediated. And ever since I've talked to him, we continue to do C3, C4 in all our ABO incompatible transplants, just as a check that there are no significant deficiencies. But fortunately, our acute TMAs have, at least in the last 100 transplants, touch wood, we haven't had this kind of a rejection, but I agree that he feels that this may be related. And we also have seen that all the 6 grafts that we have had to remove, all of them show TMA.
Yes. Yeah. So another interesting report was recently we were saying that somebody, this is also from Japan, they was just examining the types of rejection or graft dysfunction in ABO incompatible. And they were telling that in these cases only 2% was antibody mediated. They have shown that 28% cases this is a cell mediated rejection.
Yeah. We've also found that our cell mediated rejections may be slightly higher than the ABO compatible transplants, but antibody mediated rejections, especially TMAs, are really sort of, I don't know why is it that the next 100 transplants we didn't see as many as in the first 100 transplants. By and large, people haven't done, but this has been reported in Japan as well, as Dr. Tanabe also felt that this was commoner before 2004. After 2004, he's not been seeing it as often as he used to see it before.
So, Dr. Alok,
yes.
So you told that you have done this only a T cell cross match. So when do you do the cross match in this ABO incompatible, and why are you performing only T cell, not the B cell?
Sir, as the patient was desensitized, as he was given rituximab in the form of desensitization therapy. So after giving rituximab, then B cell cross match can be false positive also. So we did the T cell cross match on this.
And can you tell any method which can overcome this deficiency of doing a cross match? Any enzyme being added?
Yes, sir. Flow cross match. We can.
Pronase.
Yes. Pronase. Yes, sir.
Yes.
So pronase digestion, and then you can do the cross match. If you have to do a cross match, actually we do the cross match before
prior to giving
rituximab, and after that we don't repeat.
Yes.
We don't repeat the cross match. We don't do a cross match at all.
Another question to Dr. Alok, this rituximab, how do you place the timing of rituximab in relation to your dialysis and plasmapheresis? And how before, how after?
Sir, after giving rituximab, the plasma exchange can be given only with more than difference of at least 48 hours. And
yes, you think it is removed by the plasmapheresis? It can be removed.
Yes, sir.
It is removed by the dialysis also. It is a small molecule or big molecule usually?
Sir, it is a big molecule and it cannot be removed by hemodialysis.
Yes. And another question that if you plan for if you have done this plasmapheresis in this group of patient, so how do you choose your plasma and other blood products in terms of their group and grouping? If these kinds of things happen, suppose the patient has an ABMR or a TMA, you need to transfuse blood, plasma, or a blood plasma or a platelet. So how do you choose that?
So we would prefer the blood group of the donor's plasma, because in this case, as if we give the donor's plasma, then it will not be containing the anti-A antibodies. So we will prefer the donor's plasma, sir. Donor's blood group plasma, sir.
If it is not available,
then if it is not available, then we can use AB blood group plasma.
So in terms of blood, there is no compromise. You have to transfuse same group.
Yes.
The blood products, then you have to choose either a donor's blood group or
yes.
AB blood.
Or AB.
Okay. And
Any other I think there are a few questions in the chat box also. Let's see what are these.
So Dr. Sandeep Singhal has asked, so do we require to check titers daily post-transplant, or if there is only graft dysfunction?
I think we can go ahead and not do it at all because they haven't added any value by and large.
Whenever there is a graft dysfunction.
So if there is a graft dysfunction, then do it. Otherwise, I don't think there's any need to do them. If there is no graft dysfunction, don't monitor them. Because there is no evidence to show that doing prophylactic plasmapheresis or doing a plasmapheresis based only on rise in the titers has had any difference in the outcome. So I don't think we can go ahead and not do it at all. It's only that our anxiety that the titers might be going up, but if the titers go up, then you are likely to do something. Because the fear is that if you didn't do anything, then the patient might say that if you don't monitor these titers, I think you are better off. So don't monitor it. Monitor it only if the graft dysfunction occurs.
So just one of my experience I can share that initially we used to respond very quickly. So in some patients we used to give an IVIG instead of this plasmapheresis, we are giving IVIG, but sometimes it is impure and may contain these blood group antibodies. So even you were given in 64 titer and next day you can find a titer of 512. So it can cause a more panic.
Yeah.
Yes.
Yeah.
Yes.
So the important messages you are giving is that one, rituximab small dose 100 to 200 milligram is adequate. Number two, you are giving when you give rituximab, logically you should not be doing plasma exchange at least for 48 hours. There is no use of monitoring titer after transplantation unless there is a graft dysfunction. And keep in mind that ABMR incidence is lower in patients who are ABO incompatible transplant recipients. I think most of the relevant questions have been covered, and I thank Professor Pratik Das and Dr. Avinash for that. And I think—
Can you ask Dr. Kute if he has anything to add on to
any question, any addition, any comments?
Yes, sir. For easy to match patients like A and B, we can do swab. And for difficult to match patients like O patient and non-O donor, if ABO titer is below 256, we can go do for ABO incompatible transplant.
I don't know, because now you are saying that titer is not really making a difference. But I had an opinion what Dr. Kute is saying. That
titer makes a difference only in the cost.
In the cost.
Yeah, obviously, if you do 512 and or 1,000 or 2,000 or 4,000, then obviously cost is prohibitive. Cost becomes very expensive. So therefore, you would not want to do high titer transplant. But I think as far as the outcomes are concerned, I don't think titers make any difference. In our experience also, the 6 grafts that we lost were all low titers. The high titers, we done 2 4,000, we done 2 2,000, we done another 2 more than 1,512 many, but none of these grafts were lost. But we have had lost at 128, 64, and those are the grafts which we have lost. So I think titers don't make much of a difference.
The question is also of possibly those grafts where the titer is more, possibly they can go for immunoadsorption. That possibly works out cheaper in them, and more so in Indian scenario when you are reusing the glycosol cartridge, and you are effectively reusing 2-3 times. So possibly if the titer is less, go for plasma exchange. If the titer is more, possibly immunoadsorption may be more cost effective, I'll say.
Yeah, more cost effective, as well as the number of days that you spend in the hospital are going to be much less with the immunoadsorption columns. With plasmapheresis, doing for 4,000 titers is going to be a long month kind of that's not feasible. So I think high titers above maybe 256, 512, go for immunodesorption columns.
Another thing is that in other part of the story, even if you have a very low titer, we have transplanted one or two with a very 4 or 8 titer, it is always better do 1 or 2 plasmapheresis, because doing nothing, we have, as Sir was telling, we have also lost some, is a very low titer. So in the plasmapheresis, you can remove some complement, inflammatory milieu that can be removed, and that helps in keeping the graft better. So even in the low titer, 1 or 2 maybe plasmapheresis, it is helpful, that we have seen in our experience.
Yeah, I am not. We've had about 12 patients whose titers were less than 1:8. We didn't do anything except give rituximab. Fortunately, touchwood, we've had all good graft functions and they're doing well. In Japan, actually, see, there is a lot of science, little bit of science in it, and a lot of art in all of this. In Japan, people are not doing any plasmapheresis up to a titer of, some centers up to a titer of 62, 64.
64.
Most of the centers don't do anything to a titer of 1:32, most centers. And there are some centers in Japan, they don't measure titers at all. They do 3 or 4 plasmapheresis and do the transplant. Irrespective of whatever the titer, they don't measure titers. And the outcomes of many of these have been reported to be similar. I have had presentations from Malaysia and Singapore and some other centers where they did not do any desensitization except giving rituximab for titers up to 1:128, and the outcomes have been given as same. So what do titers mean? Are we measuring what we measure in the blood? Are these the titers which are important? People have also looked at that there are different kind of receptors at the endothelium, ABOi receptors, which have different kind of antibodies which bind on to them. So maybe there is some molecular transformation of these antibodies. Does it happen before or does it happen after loss of accommodation? No one knows it. So there are unanswered questions as far as ABOi incompatible transplant is concerned. The only good thing is that by and large, whatever we do, we are successful. But what is the science behind what we do? I don't think people understand it completely. It is like that we treated glomerulonephritis with steroids. We didn't know the pathomechanisms of all these, and many of these glomerulonephritis did improve. Same way, at the moment, we are successful with ABOi incompatible transplant. I don't know, I understand all the science about it, of what we are doing and why we are doing that. But at the moment, whatever we are doing, we seem to be reasonably doing well. So I think there is still unanswered questions in ABOi incompatible transplants, which I am not very sure about.
Well, there's no doubt. There's no doubt. But possibly most of the centers in India are conservative, and I don't know if the RNT what they are doing, but generally most of the center want 1 in less than 1:16. What is RNT doing? 1:32 or less than that?
Yes, sir. We are doing is 1:32 or less. But
even if it is 1:32, you still go ahead for 1 or 2 plasma exchanges.
No, usually, initially, there's a cutoff 1:32, you will go for 1 or 2 plasmapheresis. But
no, even at our center, we do 1:16 and less. We will go for. So our target is 1:8 or 1:16.
Correct.
But above that, we will do desensitization in form of either plasmapheresis or so. Yeah. No, even at our center, I'm only saying that various centers across the world are doing different things. There are centers which are not using rituximab. There are people who are not using IV immunoglobulins. So across the world, there are people. So we don't know. There's a randomized trial done by Doris Segev, rituximab and no rituximab. No difference in the outcomes.
So I think we had a good discussion, though there are very gray areas which we are still not clear. I mean, many centers in abroad are not using rituximab. Even John Hopkins, they are not using rituximab.
Yeah.
There are some centers who are taking titers, as Professor Kher was mentioning, up to 1:128. There are some centers who are not doing titer at all, just 3-4 plasma exchanges and go ahead. So I think this is an art, and there are many unanswered questions. But whatever are the relevant questions, what we need to know, what we need to practice, I'm grateful to Professor Pratik Das and Avinash. They have given the answer, and also to Professor Kute and Dr. Nauka for very nice presentations. And I think Professor Kher is again a master in ABOi incompatible transplant. He has got again a few publications in that field. And I think the students have got majority of the answers they've expected. Professor Kher, sir, I'll request you to close the session.
No, I think it's been a wonderful, wonderful session. A lot of things to learn about it. And I would thank both the presenters, Nauka as well as Alok. Extremely well done. And thank Pratik and Vivek. And of course, General Varma is as charming and as eloquent, always very, very erudite and good speaker. He's the master of the program. So I think thank you, and I must say we must thank also Deepak and Mr. Raja from Microlabs for providing all the background kind of. See again, meet another 2 weeks, and we will have the next section of the master class in bedsides. Thank you very much, and good night.
Bye-bye.
Bye-bye.
Thank you. Thank you.
Mr. Raja.
Okay.
Thank you, Mr. Raja.
Bye.
Bye.
Bye. Bye.